The title of my talk will be about on virtual tutorials. My name is Yasin Tayyam. I hold MD degree from Al-Quds University in Palestine, and I have also PhD from the University of London in the UK. I have been the Vice Dean for Academic Affairs at the College of Medicine and Medical Sciences, Arabian Gulf University since 2018. And I am Associate Professor of Pharmacology and Therapeutics also at the college since 2013. The outline of my talk is the following. First, I'll be talking on the timeline of the AGU response to the COVID-19 pandemic. Then I'll be talking on the virtual tutorials training. Then the technical support for tutors and students. Then I'll give you an overview on the survey that we have done for students and the tutors. And then the challenges and conclusions of this endeavor. And then at the end, I'll be giving the special thanks and appreciation for those who supported us in this effort. I just want to attract your attention that the curriculum at the CMMS is problem-based, which means that problem-based learning tutorial in small groups is a major component of learning. The first part of my talk will be about the timeline of AGU response to COVID-19 pandemic. On February 21st, 2020, the first case of COVID-19 was reported in Bahrain. And here I'm quoting from one of the local newspapers. Bahrain coronavirus case number 1, school bus driver. 6 new coronavirus cases announced, 3 schools closed. On February 26th, all educational institutions were closed in Bahrain. Again, I'm quoting, COVID-19, schools, universities closed for 2 weeks in Bahrain over coronavirus fears. On February 27th, the first meeting in the College of Medicine and Medical Sciences, deanship was held in the presence of the dean and the vice deans to discuss the situation. On March 8th, the first meeting with the AGU leadership in the presence of the president, the vice president, deans, and vice deans was held to discuss the condition. From March 9th to March 16th, the AGU decided to go online. And we selected the best platform for virtual tutorials. At that time, we had several options. We had Moodle, Google Hangouts, Microsoft Teams, or YouTube Live. However, we selected Moodle, Big Blue Button, because students at AGU are familiar with Moodle already. On March 17th, training for tutors on virtual tutorials using Moodle Big Blue Button was started. The training was conducted on campus by the CMMS e-learning team led by Mr. Arpan Stephen. The training was conducted in small groups with social distancing. On March 22nd, the first virtual tutorial in CMMS was conducted successfully. And this picture shows one of our tutors giving the first online tutorial on campus. On April 7th, the first meeting of the curriculum committee was held to develop a plan for teaching and assessment in light of the uncertain situation. And here I'm quoting from this meeting. Teaching and assessment for phase 1 and phase 2, given the current situation of temporary disruption of teaching at the AGU due to the COVID-19 pandemic and the unlikely return of students to the AGU within the period of this academic year, the following proposal is suggested. Distance learning will continue using Moodle. This includes tutorials using video conferencing. In addition to that, a robust attendance monitoring system was adopted to minimize student absenteeism. Absent students were contacted right after the first session of the tutorial to look for and solve their problems. And here I'm showing the first email that was sent. It was sent on the 25th of March, which means after 3 days of the first tutorial. Dear student, I'm sending you this email because our monitoring system has revealed that you were absent from session 1 of the tutorial number 1. I would like to emphasize that the AGU has set up an online learning platform on Moodle for students to utilize it for a tutorial, and that we expect all of you to participate in it. The second part of my talk will be on the technical support for tutors and students. Immediate technical support was given for students by the e-learning personnel via WhatsApp groups, chats, and videos. Each tutor has a WhatsApp group with his tutorial students also to facilitate fast communication. Technical support was already also given to tutors by the e-learning team by 3 WhatsApp groups, which included all tutors in each unit along with the e-learning team and the Vice Dean for Academic Affairs, again to provide efficient and fast technical support for the tutors. The third part of my talk will be about the survey for students and the tutors that we have done. Survey for students and the tutors was conducted after 1 month of starting online tutorial. From students, we have received 154 responses. So we asked them several questions. The first question was, in general, using Moodle is an adequate alternative for learning in the current situation. After 154 students, 66.9% agreed to this question. Interaction with the tutor using Moodle is adequate. 60.4% agreed to this question. Interaction with students in my tutorial group using Moodle is adequate. 60.4% agreed to this question. I prefer to continue tutorials using Moodle until AGU opens. 60.4% agree to this question. Some of the comments we have received from students were, one student said, adequate time, it's more comfortable at home. Another question said, it's more fun. Another student said, saves time as I do not need to commute to university. We have done also a survey for tutors. For this, we have received 38 responses. The first question that was asked to the tutors, interaction with the students in my tutorial group using Moodle is adequate. 89.5% of tutors agree to this question. Group dynamics in tutorial session 1 was adequate. 78.9% agree to this question. Technical support during the unit is adequate. 97.4% agree to this question. Challenges and conclusions. Some of the challenges we have faced were the following. It was a rapid shift to online tutorial. There was a need for more technical support staff for tutors, and for that we trained lab technicians and we used them for this purpose. There was also a limitation for storage on Moodle because we had recorded the tutorials and we wanted to save them to Moodle, but we faced the problem of storage space. Some of the students also experienced poor Wi-Fi connection, especially for students who are residing mainly in remote areas. Increasing interaction with the students improved with time. Conclusions. As a result of the timely response to the COVID-19 pandemic, The AGU, with strong support from the higher administration of the university and the College of Medicine and Medical Sciences, along with the dedicated technical and administrative support from all stakeholders, the BBL virtual tutorial was successfully launched at the AGU. Special thanks and appreciation. I would like to express my deep thanks and appreciation to the AGU and CMMS leaderships, the President, Dr. Khalid Abdulrahman Al-Awhali, the Vice President, Dr. Khalid Saeed Tabbara, and the Dean of the Medical School, Professor Abdul Halim Difallah, for their support of this initiative. Special thanks also to the e-learning unit staff, Mr. Arpan Steven, Mr. Akash, and Mr. Andrew also for their support, and Ms. Mariam from the Vice Dean's office. Also special thanks to the technical staff, Mr. Sendan, Mr. Tommy, Mr. Rodrigo, Mr. Siam, and Mr. Anthony. Also, I would like to thank the tutors of Unit 3, Unit 6, and Unit 9 for their cooperation and support, and for our students also for their cooperation and for taking the new change. Thank you for your attention.
Thank you, Dr. Yasin, for the simple and elegant presentation. You really walked us through all the steps in the process of adaptation of virtual tutorials. Most of the questions that were asked in the group has been answered through WhatsApp. We will wait for some more questions to come. Meanwhile, we will start with the second session. I'm happy to invite our next speaker of the day, Professor Tesir Garada, to talk on the topic, Adaptation of Medical Simulation and Professional Skills Teaching. Over to Professor Tesir.
Yasin, remove your screen, please.
Yeah, sure.
Yes, Professor Tesir, you can start the session.
Assalamu alaikum, everybody. Good morning or good afternoon. I don't know the area each one of the participants are. I will talk differently in this session about the adaptation of medical simulation in CMMS and AGU. I am the director of medical simulation program, and I am an active member of medical department. I have been graduated as a physician, as a cardiologist in Ireland, Dublin, and I have FRCP. I am the director of the medical simulation program. And as you know, to tell the adaptations that I have made in the medical simulation program for medical students in year 5 and 6, I have to go through the previous era before the corona, where the routine examinations and simulations was going on daily basis. So my talk would be mainly two components. The first one pre-era, pre-corona, and the second one is after corona. So by and large, I have nothing to disclose. And as you know, medical simulation is artificial representations of real-world process to achieve the education goals through experiencing learning while remaining contextually appropriate and realistic. It emulates clinical settings aiming to learn the technical skills and competency required in healthcare. So medical simulations in the last 30 years has been improved, and there are big strides through the high fidelity mannequins. However, there is a non-medical use of medical simulations in different era, as you can see, mainly in the military and in the pilot experience, in addition to the court. So by and large, simulation technology in medical education is based on computer-based simulation, virtual environment, part-task trainers, low-fidelity mannequins, as well as high-fidelity mannequins, with hybrid simulations where all the clinical skills go on with SP. This is the kind of contour of our medical simulations. And as you can see, we have 4 medical examination rooms, 2 briefing rooms, and a task trainer room in addition to the theater. We have 4 medical rotations. We have started 2 years back with medical rotations of 18 weeks. We have 5 cycles every 2 weeks, and with total of 6 cycles. And medical students will come every 2 weeks, once for 2 hours and a half, and he will have clinical immersion for 1 hour and a half, mainly briefing immersions and debriefings for 4 minutes after. And that would be followed by part-task trainers skills again. And all the students will attend rigorously. And these scenarios, which I will show later, are part of the integrated part of their curriculums. Surgical rotations is similar to medical rotations, but less cycles because special surgery were not included. Obstetric and gynae were 8 weeks total with each rotations with cycles of 5 and then once weekly. A pediatric is the same like obstetrics because there is only 8 weeks cycles. This is our center where one of the clinical examination room, and these are the corridors and the rooms in the center. In addition, we have the facilities where the medical learners are talking to the consultants while he is in the middle of interrogating his SP and his high fidelity mannequins. And the patients will have the objectives at the beginning as a briefing, then that would be followed by full clinical examinations and then investigations, and the 2 active students would be kind of subject for further plan of management, and all this would be discussed in the debriefing. Afterward, debriefing would be 2/3 of the talks, while the examination and briefing would be less than 1/3. This is the control room where the facilitators are observing all the group, and he also pretend to be the patient himself by going through the high fidelity mannequins, and I will show you.
Professor Tesir, can you increase the audio of the video, please?
It's the maximum.
It is not audible, Professor Taysir. I'm afraid that's not audible.
Yeah, okay. This is it. So in summary, this is actually a video of a new center in United States. And this is the summary of what these friends talk about, the doctors and the junior doctors. The students practicing real scenarios before they practice in the hospital. clinical practice making perfect. Student can repeat the examination many times and learn from their mistakes. In addition, they improve patient safety and make the hospital safe place to practice. And this video is about our center. The student is taking history from the patient after the briefing. So the facilitator is talking on behalf of the patient. Now the student will talk to the consultant on call. So the consultant gave the advice about patient. This is the debriefing session now. And this is about the HoloLens practice, which we have in obstetric and gynae. And as you can see, 3 dimensionals of the uterus. This is body interact. And here is a case of immersion on obstetric. Now he's talking to the patient now. He's telling her everything is okay. Now this is the facilitator again helping on patient side. The last is about task trainer cases. So these are short 30 minutes each where the student will have a skill. These past star trainers are add-on to the immersion on daily basis. So there is a short part task trainer and long immersion case. She is doing lumbar puncture for a pediatric patient. She's measuring the pressure now. So there were methods of delivery of medical simulations, as I mentioned. Once every 2 weeks for 12 weeks. Surgery is 2 weeks for 12 weeks, once every week. And then obstetric and VDR once every week for 5 weeks. And these are the scenarios. This is the form that we developed the scenarios. We have many scenarios I will show you later. And as you can see, we start with the names, gender, and the overview of the case or synopsis and summary about the case, the history and background. And then we talk the objectives and the outcomes of the case. And then we have the monitors that required for the case, equipments needed, and then we have our notes about the case. And we write down clearly the take-home messages and the references of the case. And then it depends on the specialty of each case. The scenarios would be different and it would be tackled differently. These are the lists of obstetric simulation sessions, and they are 5 cycles, as you can see. And each one of them will have immersion and part-task trainers. And the duration of each cycle is around 2.5 hours. And it happens that the attendance is nearly 100% in all the sessions. This is the medical cycles again, and we talk about atrial fibrillation, acute MI, asthma, and pneumonia, and then hypertension crisis, and then the hepatosplenomegaly, ascites, and then bacterial endocarditis, and sickle cell disease, and finally we talk about pulmonary edema and aortic stenosis. And these are the surgery sessions, and as you can see, there are varieties of starting for breast examinations, and we end with ischemic legs. The same for pedia. We have many different varieties of examination, with neonatology examination, acute gastroenteritis, IV cannulation, acute anaphylaxis and bronchodilators, acute bronchiolitis, tetralogy of Fallot, and SVT, lumbar puncture, and acute meningitis. And unfortunately, when the coronavirus spread at the end of February, and we have the masks, and we were enforced to stay at home and not to come to the hospital or to the AGU, and the classes, as you can see, were not attended by anyone, and only few people are allowed to come to the university. And it was, as usual, we need a little time to think of what's the best. And already my colleague, Dr. Yassin, went thoroughly about what has been done at administrative level and at the team level and students level. So you were not able to attend the university, and then the MS team tried to best to help the clinical department students to pass this critical period of time successfully. And we were thinking of alternatives, and in order to accomplish the electronic learning that has been adopted in the university in medical simulation term, it was hard, simply because the skills cannot be given or on a distant learning basis, and the patient and the student has to be encountered. However, what we have done is we were a little bit late behind. We were giving lectures. Simulation is not lectures, as you know, so the agenda of selecting the topics that has not been given previously, and we had 2 sessions or 2 topics that has to be given and addressed. And I will show you how we done the hardware required to have electronic learning sessions was purchased and prepared. And it was 2 Apple iPads and Apple AirPods, as well as the holder for iPads, and 2 stands for camera. And then we have started actually a half an hour educational sessions with our facilitators, and there was a direct transmissions through the iPad with the help of Mr. Stephen and his team. And there were 25 medical students attending each sessions on daily basis. And for instance, medical department of 75 has been divided into 3 consecutive sessions of 25 each. And the students at the end were allowed to have kind of interactive questions. And also during the sessions itself, they were allowed to have interactive questions. So the facilitators and another facilitators, one of them pretend to be the patient and the other one is pretending to be the facilitators, and they were giving the same as before. There is objectives, there is examination history, and the students were observing all this through the iPad and directly. And then at the end, there is a take-home messages in addition to the debriefing, where all the medical students were kind of participating in the discussions. And these are the PDS sessions, and there is also surgical sessions by Dr. Ahmad to ensure the error-free sessions and to overcome any possible technical errors. The sessions were conducted by the MSS team and helped by the electronic learning staffs. This helped optimize conductions of the simulation sessions and make it interactive sessions. And the actual electronic learning simulation sessions last for 30 minutes each. I have just mentioned earlier. And then it was continued daily on daily basis, starting on the 4th of May for some groups, 25 students attending each sessions at one time. So these sessions were conducted daily and operated by the facilitators. And as I mentioned, one of them was learner, the other art trainer. The electronic learning team was supported by Mr. Stephen and enabled by the high definition simulation sessions, where the student is the BBB integrated in the model. Simulation with high definition broadcast using the BBB has been chosen for the video sessions, and the whole simulation sessions was recorded, made immediately available to the student access through modules, and everyone is opening through his own accounts with the Moodle system. And the transmission was live broadcast, and the entire sessions was interactive, where the doctors and the students communicating with each other during the sessions. So challenges ahead were no real clinical skill with hands-on gained. However, at least we were able to deliver some medical simulation experiences, at least at the cognitive levels. And we hope that the psychomotor part of the simulations would be soon elaborated by having smaller group with a social distance and then less than 4 or 5 students in one group. And we hope by establishing and expanding our simulation center, we would be able to cater with the crisis of Corona, the full clinical skills, but with this number of students and adopting fully the careful sterility technique. Thank you very much for your attention.
Thank you, Professor Tesi, for the informative session. Your videos brought out the magnitude of work done by a medical simulation center. We have a question for you from the participants. Do you use SNAPS method, SNAPPS method in simulation?
Yes, actually, we do it. We do this as a part of the practice for medical simulations.
Okay, thank you. Thank you, Professor Tesi. Now we have a question for Dr. Yasin. Dr. Yasin, are you with us?
Yes, Archana. Yes.
Yes, 1 minute. I'll read the question. Thank you for the presentation. Presence of student online is not synonymous with engagement. How did you ensure that they were engaged? Because Nearly 40% of the students have not agreed that online learning was effective. Were there any open-ended questions which helped to answer these issues? Did all your students and faculty have a stable internet connection? Over to you, Dr. Yasin.
Thank you, Dr. Archana. Thank you for the question. It is very expected that students may not feel that they are engaged at the beginning. As I said in my presentation, the shift from face-to-face to online tutorial was very rapid. However, we are pleased that despite that, 60% of the students are satisfied. The second part of the question on engagement, this was reflected by the tutors actually. The tutors themselves, based on the survey also, they said that most of the students were adequately engaged in the tutorial sessions. Thank you.
Thank you, Dr. Yasin. Now we move on to the third session of today. It is my pleasure to invite our next speaker, Professor Muhammad Ani, to talk on the topic online team-based learning. Over to Professor Muhammad.
Good evening, everybody. It's a pleasure to share our experience in online team-based learning in the Department of Family Medicine. So we have a disruptive situation, and suddenly students were asked to stay home, and we have students from all over the region, and they had to stay home in different countries. And we started like every other school, possibly every other school in the planet, to ask our faculty to record presentations or prepare presentations and add audio to the presentations. And then we thought about the clinical aspect. We had our year 6 students who were usually trained in the family practice centers, and for the clinical aspect, we add some case studies at the end of each presentation. It was not satisfying neither for us nor for the students. Then we started to brainstorm together to find an alternative for this family medicine clerkship for the students, and we decided to start using a modified version, a modified form of the team-based learning. We brainstormed about the preparatory, what are the preparatory steps, and we had only, we started this very somehow late, and we had no much time to prepare, but we used what's already have been there, and we started faculty orientation. As you can see, we started Zoom meetings with the faculty to explain the process to them and the principles of team-based learning, and how are we going to use Zoom and the breakout room function to conduct team-based learning. We also shared with the students a guide to team-based learning by Maguire University, and we also shared some kind of student orientation about their role, what's expected from them, and the steps to conduct successful team-based learning sessions. The content of the team-based learning sessions included role play, which is a modification that we've added. We started the team-based learning sessions asking the students first to watch the presentations with the audio in preparation for the session. Then as we start the session, we start with role-playing a scenario that's relevant to the theme of the team-based learning activity. And here's my dear colleague, Dr. Fatma Habash, who's among the participants today. Thank you for allowing me using your picture. She is conducting the role play with one of the students. As you know, most of the students prefer to keep their camera off during the online sessions. She was conducting the role play. Then we used the usual IRAT and TRAT for the students using Google Form to prepare the questions, and using the breakout rooms to put them into teams who work together to solve the questions. I will take you through this in more details. So the process of the family medicine modified TBL was that we prepared, before the session, we prepared the role player scenario. We developed the MCQs together, me and the lecturer or the tutor of the session, and I developed, and Dr. Fatma helped me in developing the Google Forms. We use 2 different forms, the IRAT form for students, individual students, I mean, and the TRAT for groups of students. So now we are starting the session. The tutor role plays the scenario. And after that, this can cover the following skills: communication skills, as you all know, history-taking skills, clinical reasoning skills, health education and explanation skills. After conducting the role play, the tutor, and maybe sometimes I assist in this, we give feedback on the performance for the students. We allow the student to give feedback about his performance. We allow his colleagues to give feedback about his performance. Then we give a structured positive feedback about his performance. And afterwards, we share a link on the chat function of Zoom with the students for the Google form of individual RAT, the reassurance test. And for each theme, we used from 10 to 15 MCQs, all with clinical vignettes. We wanted to make sure that the first set of questions are usually linked to the scenario, the role-played scenario that we've just role-played with the students. We also use some questions that has data interpretation, which is another clinical skills that we are aiming at in our TBL, family medicine TBL sessions. We also used clustered MCQ with another different pictures, like for X-rays, ECG, dermatology pictures for skin lesions. So we made it really a rich experience for the students to go through. While students are solving their MCQs, individual responses were monitored. We were monitoring their performance. And for the individual reassurance test, students were not provided with neither the correct answers or the marks. They had no clue about the right answers. They just solved a set of 10 to 15. In this case, it was 20 questions, 20 grades, sorry, 10 to 15 questions. And they receive no feedback about the correct answers or the grades. Then we use the breakout room function again to break the students into 6 groups, 6 to 7 students in each room. And before they go into the rooms, we share another rank for the TRAT and ask them to assign a group leader. And same time is given for them to discuss and resolve the questions that they have been working on individually. And the group leader is asked to upload the response of the group on the IRAT. Now, when they upload the response of the group, it has a different design. It's designed as a quiz, and the missed questions are there. The marks are released. The correct answers are showed. So now when they are working in groups, after they submit the answers, they can have feedback from the Google form. A good addition that we added to this process was, for example, we have 6 groups of students. We create 7 breakout rooms. And in this 7th room, in this additional room, I take all my colleague tutors. In this case, in this picture, we are 3 tutors. We go together in a separate breakout room and watch while the students are submitting their answers. We take a look at the individual performance, then we understand the weaknesses among the whole group. We agree on areas to emphasize in the upcoming discussions. And we also take a look at the group performance and see how much was added by working in teams to the level of performance of students. So this was a very, very useful step in conducting our team-based learning sessions. Then students are brought back to the main room. We have an open discussion to highlight the value of working in teams. We show them the scores without the teams. We show them the scores, the groups of scores, the scores of the groups of the teams. We allow them to appeal for the questions and discuss and explain the questions. The one by one, we go through the questions and explain the correct responses and give them feedback about any misunderstanding or any misconceptions. We allow them to ask for more and more clarifications, general clarifications of the topic of the theme that we are covering. Then this is followed by a summary and recap by tutor. This whole process took for anywhere from 1.5 hours to 2 hours for each theme. Okay, what about the results? This graph shows the difference between the individual work or the individual grades in each of the themes and the team's grades. As you can see, there is significant improvement in the performance of the students in 6 out of 8 themes, and in 2 of the themes, which is low back pain and ethics, there were no improvement whatsoever in their performance, which means that these 2 topics our themes are generally they have common, the batch or the cohort of students that we were teaching had shared the same weaknesses or problems in understanding these 2 topics, and this was explained in the discussion. Then we asked the student to submit their feedback, which is very valuable to us. As you can see, the blue color is for strong agreement. We gave them these 10 statements, and we asked them to either strongly agree from a scale from strongly agree to strongly disagree. Please do not use the annotations. So for the technology, it was easy for them. The best thing was using Google Forms made the session more useful for us. Also, discussing questions and other aspects of clinical application was useful. The worst performing parts of the TBL was that improved their communication skills, because most of them had no chance, because we allowed only 1 student to role play, and we hardly can get a volunteer for the role play from the students. And they don't think it's an acceptable alternative for clinical training. And of course, we can see why is this. But generally the feedback was on the positive side. Verbal feedback, what aspects were most useful? These are the exact responses of the students. Discussion of the previously answered MCQs was very helpful. MCQs individually and in teams, followed by discussion with doctors. This was the most useful part. Sessions explained on a PowerPoint presentation with voice notes prior to the TBL, and the presence of MCQs during the session, which showed us the weakness points and what we need to read more about, and the questions that we're able to discuss or even ask the presenter. So they really value the opportunity to get more explanations, and that working on MCQs more than 1 time and then have a chance to solve it with the tutor help them to deepen their learning experience. Discussing MCQ answers and role playing, some of them thought that it was useful, and Google Form questions also, there was an agreement that using Google Forms was a plus. Recommendations for improvement, much more useful than usual sessions given in lecture halls. I agree with this comment. However, the only weakness was that we couldn't practice efficiently history taking and clinical skills. It was perfectly done except for the timing. Should have been earlier, not so close to the exam day. This is also a learned lesson for us. Discussing more topics was a recommendation, and make it a part of the problem-based learning system, which is, this means that they value the team-based learning as an effective learning method. Finally, we have our lessons learned. TBL is an effective and engaging tool for teaching students in clinical years, not only in preclinical years. Students prefer TBL over didactic traditional lectures in lecture halls. Students enjoy working in teams, and more importantly, they learn from each other. Live interactions with the students is crucial for better learning experience. More focus on communication skills and allowing more students to participate in role plays will be a future direction, inshallah, in these team-based learning sessions. Instant analysis of group responses was important for conducting discussion and directing the discussion in the next parts of the team-based learning session. That's all. Thank you very much for listening, and I hope that you find this useful. Thank you very much.
Thank you, Professor Hani, for the very engaging session. We really appreciate your practical ways of explaining the complex process. We do have a few questions for you. How many students were there in one team?
Yes, the whole cohort was, it's the clerkship working in the family medicine. was 40 students, and in each group we split them into groups of 6 to 7 students in the breakout rooms, I mean. The
next question is, do you think this may be applied for large number of students as it happens in our faculty where there are more than 200 students every year?
Yes,
is it applicable?
Yes, we have a published paper in medical education adaptations with my colleagues from my old school, Hilwan Medical School, and led by my colleague, Dr. Dalia Gaber. And she managed to conduct team-based learning for pre-clerkship for 900 students.
Okay. And the last question is that, were students given the pre-reading about the clinical scenario?
Yeah, they have a whole lecture PowerPoint presentation with audio added to it.
Okay, thank you, Professor Hani. Thank you very much. Now, dear viewers, we have saved the best for the last but not the least. It is my honor to invite our next speaker, Professor Rami, to enlighten us on the topic online clinical teaching. Over to Professor Rami.
Thank you very much. My name is Rami Agan. I'm currently the head of the Department of Surgery at Arabian Gulf University. And previously, I was the Vice Dean for Clinical Affairs at Jordan University of Science and Technology. Today, I'm going to have with you a quick review of the response of the clinical departments during the COVID-19 crisis in the Arabian Gulf University. I am honored to represent my clinical colleagues in this respect, and I'm taking some of our activities in the Department of General Surgery as an example of that, but also I'm going to allude in the general activities of other departments. Now, the first issue, which I think was the most important, is the decision. One of the easiest decisions in such crisis is to say that, especially for the final year students, we need junior doctors. Let us go and graduate them. Let us put yes or no questions, fail or pass, and that's it. That's an easy decision, but might not be the best to serve the interest of the students and the university. The other issue here, during the response of our university to this crisis, was that we are dealing with a two group of patients in the clinical clerkship. The first group was the graduation year, which included year 6. And this mainly was the general surgery, the ophthalmology, the NT, the psychiatry, and the community medicine. These were graduates, and it was a very urgent matter to find a way to graduate these students, but at the same time not sacrificing the level of the students and the achievements of the university. The other group of clinical students was those who were in year 5, and those students usually are taking the gynecology, obstetrics, and the pediatric training as the main training. And we had the decision by the leadership of the university was that we have to graduate the year 6 students and do our best by online teaching and find what are the alternatives we have. Year 5 also, they will have online teaching and online activities, but also part of their training will be postponed till the next year, so that if there is a finishing of this crisis, then we can give them some extra time at the start of the next year. So that was a very good, brave decision at that time. Now, this is the final year student program distribution. As I said, we have 17 weeks of surgery, 2 weeks of ophthalmology, 2 weeks ENT, 4 weeks psychiatry, and 4 weeks community medicine. So you can see that there was a big load on the Department of Surgery and the attached departments to it, the ophthalmology and the psychiatry department. So This meant a very important issue that all we had to work in a team so that we can have a good achievement. Now, if you look at the training of the clinical training of the students at that time, when the crisis started, the level of training of students was different according to which group was the patient belonging in. For example, those students who were in the general surgery have already finished 50% of the clerkship in their regular training. And that was partly reassuring because these students have been actually exposed to some of the basic skills and some basic ways of how to take history and physical examination. However, in the same rotation in the final year, some students actually were not exposed to any experience. For example, in the ophthalmology department, ENT department, psychiatry, or community medicine, half of the students had completed training while other students had no training at all. So that was a very challenging matter. Now, at this stage, when the university took, in my opinion, a very good decision to try to carry on by online treatment, teaching, and try to find a way to compensate for the lack of clinical experience, we were faced by several issues. On top is the students and how you are going to deal with the students themselves, how you are going to deal with your staff, what are your available facilities, both clinical and academic. What is the role of the administration? How can you make communication between different departments? There always should be a continuous feedback, frequent feedback actually, from both the students and the teachers. And it's very mandatory also to find the experience of other institutions in this regard. And unfortunately, by that time, there was no such help. And by that time, some universities have already taken the decision to make it easy and just graduate the students. But we were, I think, one of the very early universities who decided to find a solution for this. And because assessment is a major part of teaching and learning, also the assessment process, it has to be modified so that it can serve both the learning purposes and the assessment purposes themselves. And remember that at the end, the departments should write whether they think that the students can be graduated or not. We had also a pressure of time, both on the students and the health authorities, because if you delay the graduation of your students, this means that their internship is going to be delayed, then their residency is going to be delayed, etc. And this is happening in a time where actually most of the countries are in need of junior doctors as a first line or front line doctors. And last but not least is the financial burden on the university, because now you are using new techniques and you have to react very quickly to the current situation. So we had to consider all these into consideration. Now, one of the important issues in such crisis is to remember that the student is the core of the response. You have to, we always say that self-learning is the core of any learning process. So among preparing the responses, we should also emphasize the role of the students. And for example, in the Department of Surgery and other departments, we had continuous contact with the students, telling them that they should pay more time, more attention. And we also made it clear to them that here comes the role of taking more emphasis on the books which teach the students how to take history and perform physical examination. This is from their own side. And I remember when a group of students contacted me, they were very worried. They didn't know what to do. So just I reminded them of a famous say for Ibn Sina, he said, I continued until I had made myself master of all sciences. I now comprehended them to the limits of human possibility. So you have to find a reassuring way to talk to the students and let them know that they are still the core of the response. Now, remember that the students have ambitions. They want to finish their year. They are worried about delaying the graduation process because everyone has his own plans for the future. Some students are going to continue teaching their residency in Bahrain. Some are going outside. So here you have to understand there is a problem with these students regarding what they expect. At the same time, you have to use a special language in talking to the students. You don't want to increase their frightening and worrying about what we are going to do with the graduation. But at the same time, you should also let them know that at any time we are not going to sacrifice the reputable standard of our university. And that was a difficult balance sometimes when we were addressing the students. And as many studies have showed, the stress which happens to the students during crisis also should be understood when we are evaluating our teaching methods and the upcoming assessments. So now, let us concentrate more. What challenges were actually facing the clinical departments? We have a problem in finding alternatives to the clinical training activities in the hospitals. Also, there are activities which are held in the campus itself, in the Arabian Gulf University campus. We have continuous assessment tools, and these tools help our students in learning. They encourage and make sure that students are adherent to our standards. And then there are the regular examinations. We have many types of examinations for our students: the short essay questions, the multiple choice questions, the OSCEs, and the real clinical encounter exams in the hospitals. In our university, these exams are also considered an important part of the teaching process. So all these things were to be considered. Now, the previous problems may be applied to all the phases of medical training, but in the clinical life as well, we have a problem of the lack of physical encounter with the patients. Whatever you do, the patient is not encountering the student directly. And there is lack of hand-on experience. I mean, the patient can get the description of how to examine the abdomen, but he will never feel the spleen if the spleen is enlarged online. And this is a very difficult issue to tackle, actually. And then, as I mentioned, the assessment tools and the assessment process as a whole should be tackled. Now, as it comes to the final graduation year, as I said, it becomes a very important balance whether to graduate the students or not. Now, when it comes to the faculty members, also, we have extra problems. Now, in such crisis, you have to depend on senior members. And this means that you have less number of persons who are going to help you in this. And also, the staff of themselves have now changing environments. Some of them have to change their hospitals. Some of them has to change their practice. Not forgetting also that there is a big stress on the staff because they are facing this crisis. So also we have problems with the psychological response of the staff themselves. It's very important to know what are your training needs for the your staff. So from the start, our department and the clinical departments started to take training sessions, which includes how to discuss with them using different applications like Zoom or Microsoft Teams. And later on, when we are going to use the MCQs, what is the available ways online, or how to prevent cheating. And we also made workshops under the direction of the Vice Dean for Clinical Affairs of how to make recommendations for the universities to put laws, how to prevent cheating in the future when we are going to use the online treatment. And also putting new laws and the new recommendations for the new situation is a very demanding procedure. And luckily we found that our colleagues from the hospitals, who are a major part of the faculty, actually, most of the faculty in the clinical departments are part-timers working in our affiliated hospitals. And I like to thank them because they were very keen to attend all the training sessions and all the mocks we have done, and they were a very important part of the process of what we have done. We also had the space problems because we have lost the rooms in the hospitals, and we need spaces for the online teaching using the Zooms. We have transformed our offices in the university actually into teaching rooms, and these rooms also were transformed into rooms to make the online examinations. We had to review the technical aspects. We tried to upgrade our computers as much as possible. All these aspects, although they might seem easy at the start, but it was very difficult to make them at the start because even most of the shops which are selling these technical issues were closed. So I'm very thankful to the university administration and the leadership of the university, which actually did very good job in supporting us during this period. Now, after doing this minimum or reaching a minimum stage of training for our staff, the first stage we took in most of the clinical departments is the stage of giving the students a baseline of what we want from them. And that was through PowerPoint presentations with audio comments. But we urged all the staff here to reshape their presentations in a clinical problem-solving manner, concentration on case analysis and case studies, and to give general review of the relevant topics. And for example, in the Department of Surgery, we had introduced more than 35 PowerPoint presentations in this regard. And I think that the clinical departments in general have prepared around 120 presentations. And these were uploaded on our websites related to the university. And at the end of this stage, a feedback survey was made. And as you can notice here, most of the students found the presentations very useful to them. Now, the second stage was the stage of live interactive sessions. We ended using Zoom most of the time. Some of the colleagues also were using the Microsoft Teams. And also we concentrated on giving real scenarios, encouraging students to start from history to physical examination, then to find the relevant signs, and then how to formulate the problems in the patient. What are the differential diagnoses in a logical manner? What are the relevant investigations? And then how to recommend a certain possible treatment. So every activity was serving in this direction. Part of our training in the clinical departments is the portfolio, which is prepared by the students and submitted at the end of their rotation. Now, this has to be modified because, as I show you here, it was usually classically based on 4 elements, which is the case write-ups. The students were asked to present 3 or 4 cases they have seen during the rotation and do a complete analysis to that. Some of them actually were not having their notes even when they left the university. So as an alternative, we have given them clinical scenarios made up by the departments, and we ask them to analyze these new scenarios. Also, those students who were not able to attend surgery, we asked them to have some anatomical review, which is related to the operations, common operations they usually see. And we had added something new to encourage a student to react to the new situation, and that was how would each student react in a way so that he protects himself and his family while he is dealing with the patients who are having corona, but at the same time not compromising the interests of patients. And I think that all the departments had such type of response in which they strive to, at a very early stage, modify their curriculum even in order to prepare them for the very near future. Now, as I told you, because we believe that the assessment process is part of the teaching here, we try to find ways of how to compensate our usual clinical examination. For example, this is an example of a questions which we have called it several names: modified OSCE questions, clustered OSCE questions. Here, the student will be given a scenario, clinical scenario, with some clinical information as an investigation or an X-ray. Then he is going to be asked questions in a logical manner. Here, for example, this was a case of testicular tumor metastasis to the retroperitoneum, and then the student is encouraged to make a differential diagnosis, and then the answer will be formed in an MCQ question. And the other way of assessment was used largely by the Department of Surgery was the online structured viva. It was a 20-minute interview with the student where he was given also a clinical scenario and in addition to X-rays or pictures, clinical pictures which are related. And then in each time he was asked to take a focused history, a focused physical examination, then reaches a final diagnosis, the relevant investigation, and we used to encourage them to use their cognitive abilities to formulate the treatment and find out their ways. Now, this type of questions and the previous one here, when we compared them, actually, they were very consistent in regarding the results, which means that in a way, those scattered OSCE questions were actually measuring the clinical skills in the students to a certain degree. But we have to remember that this will never reach the level of the real clinical exam. Now here you can see the results of the students in surgery on the left side. This is the half of the students who were trained before the crisis. They have the full clinical training. And then on the right side you can see the markings of the students who lived the crisis and were trained upon the new program. And as you can see, the curves look exactly the same. And in a way, the students in the crisis period had marked slightly higher in their average. And we are sure that this was not due to the to that the questions were easier, but it seems that the students were paying more attention. Now, what are the important lessons from this? I think the first one is that you can do it. I mean, if you try to do it, then you can do it. At the start, at the first, we were hesitant. Some people were hesitant, but when you decide to do it, then you find that you can overcome many of the problems. And what's important here is this is a bank for the future. Now, we hope that the crisis will end very soon so that we can go back to the normal situation. Even in the normal situation, the experience we have gained in online teaching now can elaborate more and add to our classical teaching. And it's very important at the end for the clinical departments to sit together and give a recommendation whether they do suggest, advise that the students should be graduated or not. And happily, by the end rotation exams, all the clinical departments thought that this was very successful and this was the recommendation. So what about the future? We need now to plan for different possible scenarios. Are we going to face this same thing in the coming year? Are we going to face it partly or completely? I mean, maybe we are allowed to send half of the students to the hospitals next year. Maybe students will be allowed only to visit the university campus. So different plans should be put for different scenarios. And we, for example, in the clinical departments are planning under the guidance of Dr. Muna, who is the Vice Dean for Clinical Affairs, to put such scenarios and raise our recommendations to our Dean who actually was a very supporting person to all of us in every minute detail. And we also should consider the required spaces for the upcoming year if this lockdown persists. Technical facilities. Now, we need from now to calculate how many new computers we need, what are the new facilities we need, and actually this step has already been started by the university. What are the training needs for your staff, for your students, for your administrative staff, so that you can carry this. Now, is there a need for the curriculum update and modify it? Because if you continue in this, then surely you have to relook at your curriculum so that it can be more easily applied or applied under such conditions. It's very important here to realize that interdepartmental and multi-institutional collaboration becomes more important at this stage because, for example, if your students for a certain time they are present in another country, then there might be some cooperation between nearby countries so that we can use their hospitals or their facilities in training our students or even making the examinations. Actually, this is one of the options which was considered early in our department and by the clinical departments in the assessment process, but we found that maybe it will be considered later. So I would like to end my talk by just copying what one of our philosophers, old philosophers, his name was Moses Al-Maimuni, Moses Maimonides. He lived in the 1200s period. He said actions are divided as regards their objects into 4 classes. They are either purposeless, unimportant, or vain, or good. I'm very proud that I was part of a team which made most of our actions falling into the good area. Maybe we have done some unimportant things, but definitely nothing of our activity went in vain. And let me take the opportunity to thank all my colleagues in the Department of Surgery, in the clinical departments, in the deanship, in the IT department, at all levels of university faculty who actually were very supportive to us. And of course, I have to thank our students because they were the brave soldiers who made it easier for us to pass through this period. Thank you for listening.
Thank you, Professor Rami, for the graceful presentation, which showed us the spectacular achievement of Department of Surgery. I am positive that this experience can be considered as a template of success for other clinical departments too. We have few questions for you, Professor Rami. The first one is there any delay in passing out of final year graduates because they were unable to complete their clinical training?
Yes, there was some delay. Usually our final year will be ended by the start of June. This year we will end by, I think, 20th of July, finally, the final graduation. But actually, we also took into consideration not to make this delay till, for example, it interferes with further training, because in most of the GCC countries, the internship will start by August. So, alhamdulillah, we could make it in the proper time. The reason for this delay actually was not due to delay in decision starting the process, but actually we needed more time to compensate, because if you can give a certain or cover a certain area in 1 week in the regular teaching, then it will take more time during this crisis and lack of facilities.
Thank you, Professor Rami. We have one more question for you. What are the formative assessment tools were used during this COVID-19 pandemic?
We used to send the students some questions which are similar to the questions they are going to face in their real exams. and we used to have some feedback from them. This is because we also wanted them to be trained on how to go through the new assessment. There have been direct questions, and also there have been mock exams. The departments, with the help of the education department and the other departments in the university, made mock exams, and each student was at the end informed about his performance, without, of course, calculating these marks.
Thank you very much, Professor Rami. I now call upon our beloved Dean, Professor Abdul Halim Daifullah, who is the Director of WHO Collaborating Center for Health Professionals Education Development. He has been the pillar of support for all the academic endeavors at AGU, and I request him to propose the closing remarks. Over to Professor Abdul Halim.
Thank you, Dr. Arshana. I hope you got benefit from our experience so far. We came to the end of our virtual webinar on online teaching. This activity is part of the WHO Collaborating Center on Health Professional Education and Development. I would like to thank all participants. We almost reached around 230, 240, something like that, from around 21 countries. I would like to thank those who participate from the GCC countries, from Saudi Arabia, Bahrain, Qatar, Kuwait, Oman, and UAE. Also other Arab countries participant from Libya, Sudan, Iraq, Palestine, and Jordan. We have participants from India, Indonesia, Bangladesh, Pakistan, Nepal, and Malaysia. This is great. We have also some participants from Canada, Germany, and Mexico. This is really achieving for us. I would like to thank the WHO office, Dr. Golin Gedik from office of the WHO at Cairo. Many thanks goes to our speakers, Professor Rani Yagan, Professor Muhammad Hani, Professor Taysir Jarada, and Dr. Yasin. Special thanks for all the technical support team from the AGU, Sarah, Aisha, Stephen, Akash. Special thanks also to the IT team who was supporting us, Mr. Adnan and other colleagues. Many thanks to the support provided by the Vice President, Dr. Khalid Tabbara, and our President, Dr. Khalid Al-Ohali. Thank you all for attending our sessions, and we hope you got benefit from our experience, and goodbye. Thank you so much.
Thank you, Professor Abdul Halim. Before we conclude, we are happy to announce that we will be sharing the recording of today's session very soon with all of you. And we also request you to kindly fill the feedback form through the link provided in the chat and also through WhatsApp group. Learning is a lifelong process, and therefore we hope to meet all of you in yet another educational feast very soon. Thank you for joining us. Stay safe and good night.
Thank you.